Welcome to Nursing 200, Unit 6, Chapter 6, Care of Patients with Cancer. The epidemiology of cancer is that more than 1.5 million Americans are diagnosed with cancer each year. More than 560,000 Americans die from a malignant process each year, and cancer still accounts for more deaths than heart disease in people under 85 years of age. There's been a stabilization of incidence rates for cancer sites in men and women since 1999, and a continued decline in death rates since 1991. The features of cancer cells are their malignancy, which is the rapid or continuous cell division. Anaplasia results, which is the loose specific appearance of their parent cells. As cells become more malignant, they become smaller and more rounded. Cancer cells have a large nuclear to cytoplasmic ratio, which produces a cell that has a larger nucleus than normal cancer cells, and the cell itself becomes smaller. Oftentimes in malignant cancer cells, specific functions are lost as cancer cells can serve no useful purpose. Cancer cells also have a loose adherence as they do not make fibronectin, which makes it easier to break off from the main tumor, thus resulting in metastasis. Cancer cells also have the ability to migrate, as cancer cells do not bind tightly together, and they have a special enzyme that allows them to slip through blood vessels and tissues, spreading to other sites, resulting in metastasis. Metastasis is common in cancer cells, and the most common sites of metastasis are the bones, the lungs, the liver, and the central nervous system. Cancer cells spread rapidly through the lymphatic system, and the lymphatic system is the most common mechanism of metastasis. Tumor emboli enter lymph channels by interstitial fluid, and they also penetrate the lymphatic vessels. Hematogenous spread includes spread via the bloodstream, and that's directly related to the vascularity of the tumor. And angiogenesis is a process by which a new blood supply is formed by the tumor itself. And tumors can form new blood vessels to provide nutrition and oxygen to the tumor itself and to provide a route for metastasis. The following slide depicts the steps of metastasis and shows malignant transformation, tumor vascularization, blood vessel penetration, and arrest and invasion. Cancer etiology and genetic risk. There are several different risks for cancer etiologies, the main one being chemical carcinogenesis, such as tobacco, alcohol, and exposures to chemicals. Physical carcinogenesis is a result of radiation such as ultraviolet radiation, sun, tanning beds, radon, uranium, radium, X-rays, and chronic irritations such as sunburns or scars of burn patients. Viral carcinogenesis is where viruses infect body cells and break the DNA strands, and this is common in hepatitis B and C and HPV or human papillomavirus. Dietary factors that are associated with cancer etiology are low fiber intake, high intake of red meat, high animal fat ingestion, preservatives, dyes, flavorings, and sweeteners. Immune function, cell-mediated immunity, protects against cancer through the helper T cells. Immunosuppressed patients, such as those with AIDS, have a higher incidence of cancer. Age is another cancer etiology and genetic risk, and it's the single most important risk factor for cancer. Decreased immune protection as the patient ages and length of exposure to carcinogens results in increased incidence of cancer in older people. Lastly, genetic risk. Genetic testing is available to check predisposition or risk for a few specific types of cancer. The BRCA1 and 2 is definitive for genetic risk for patients for breast and ovarian cancer. However, these tests are expensive, and they're also not a diagnosis of cancer in particular patients. Cancer prevention. Primary prevention of cancer is aimed at strategies that actually prevent the occurrence of the cancer from happening. In primary prevention, it's important to avoid potential carcinogens. And effective primary prevention strategies is aimed at skin protection, avoidance of tobacco, and avoidance of asbestos exposures. Modifying associated factors is aimed at the reduction of diets that are poor in fiber and low and high in fat, alcohol abuse, decreased sex partners, and safe sex practices. Removing the at-risk tissues involves removing abnormal moles, colon polyp removal during colonoscopies, and breast removal if the BR125 gene is present. Chemoprevention is a newer form of cancer prevention and is aimed at drug therapy to help prevent specific types of cancers. Aspirin and Celebrex to reduce colon cancer, vitamin D and tamoxifen to reduce breast cancer, and lycopene to reduce prostate cancer. And then newly is vaccination. Vaccination is a new method of primary cancer for protection. And at the present time, the only primary method of vaccination for cancer cells is the Gardasil vaccination. The Gardasil vaccination is used in younger adults to help prevent human papillomavirus or HPV prevention. Cancer prevention, secondary. Secondary cancer prevention is aimed at screening strategies that help to detect cancer early. You want to review family history of cancer and alter the patient's lifestyle and participate in screenings. Regular screenings include a yearly mammogram at age greater than 40 years, a colonoscopy at age 50 and then every 10 years, and yearly PSA and rectal exams at age 50 and greater. Genetic screening includes screening for gene mutations linked to specific cancers. The BRCA1, increased risk for breast cancer and ovarian cancer. The BRCA2, you're at increased risk for breast cancer. And the APC, MLH1, and MSH2 genes are putting patients at risk for increased risk of colon cancer. Cancer is classified by the types of tissues from which it arises. For example, a hepatocarcinoma would come from the liver, a lymphoma would come from the lymphoid tissues, and an osteosarcoma would come from the bone. Tumors are graded and staged according to their different types of classification. Grading rates the cells based upon their malignancy, and grading is done from GX to G4. GX grade cannot be determined, and G4 is definitely tumor cells that are poorly differentiated, retain no normal cell characteristics, and are difficult or almost impossible to determine the tissue of origin. Staging is a tumor classification that determines location and size of tumor, extent of the disease, and the degree of the metastasis. Clinical staging is based on the clinical signs and symptoms the patient exhibits, the clinical signs of the tumor size, and possible spread. Surgical staging is tumor size, number, sites, spread by inspection during surgery. And pathologic staging is the most definitive, as this identifies tumor size, number, sites, and is spread by the pathological exam of the tissues obtained in the operating room. There are 7 warning signs of cancer, and if you remember the mnemonic caution, you'll understand the 7 signs. Caution, C stands for changes in bowel or bladder habits. A is a sore throat that doesn't heal. U, unusual bleeding or discharge. T, a thickening or lump in breast tissue or elsewhere. I, indigestion or difficulty swallowing. O, obvious change in wart or mole. And N, nagging cough or hoarseness. Surgery is cancer treatment. Surgery is the oldest and first form of cancer treatment used in patients, and it's used for prophylaxis, such as a mole or breast removal, diagnosis, such as a biopsy of all or part of a tumor, cure, removal of all cancerous tissues within the body, control, debulking, which removes part but not the entire tumor to increase the chance of other therapies to be effective, palliative, to improve the quality of life and reduce pain, or reconstruction or rehabilitation, which increases function, enhances appearance, or both, such as accomplished through breast reconstruction, bowel resection, or penile implants. Radiation therapy for cancer, the purpose of it is to destroy cancer cells and interrupt cellular growth with minimal exposure of the normal cells to the damaging actions of the radiation. It's used to cure, control, or as a palliative method. Teletherapy, which is the most common type of radiation, is external beam radiation. It's an external source of radiation, so the patient is not radioactive and is not a hazard to others. It requires a position fixing of the body, often using body molds or splints, or markings such as ink outlines or tattoos, which direct the therapist to know where to put the external beam of radiation. Brachytherapy is a short or close type of radiation source where a radioactive seed is transplanted into the body tumor itself. The radiation source comes into direct continuous contact with the tumor tissues for a specified time period. It uses radioactive isotopes, so it emits radiation for a period of time and is hazardous to others. And liquid radioactive iodine is used to treat some cancers, such as those found in solid or prostate cancers. The following slide shows external beam radiation and a patient being measured for a mold. The following slide here shows brachytherapy for prostate CA. The patient has a perineal template that's inserted, and a needle goes through it, and it releases the seeds that are implanted into the body. The following slide has a link to a radiation treatment video that I think you'll find very helpful. Radiation therapy toxicity. Local skin changes and hair loss that will likely be permanent depending on the total absorbed dose are often common in radiation. The skin in the path of the radiation is dry and can break down, and also could be wet and weepy. Erythema often develops 1 to 24 hours after the first treatment of radiation, and desquamation or sloughing of the epidermis or deeper layers of the skin is common. The thin epidermis is more subject to damage from trauma and delayed wound healing in cancer patients undergoing radiation. They often develop dilated red spidery vessels in the treated area, and tissue fibrosis and scarring years later can occur, especially in uterine cancer radiation, which causes changes in the colon, such as constipation and obstruction. This slide here shows radiation side effects and the effects of radiation on the skin. This slide here shows radiation burns, and radiation burns can be as mild as a small red area that looks like a small sunburn to a severe type of skin reaction that's red, weepy, and broken down. Nursing management is aimed at protecting the skin integrity. Cleanse the skin area with mild soap and water. Tepid water needs to be used, and soft cloths or hands and pat dry. Apply non-perfume moisturizing creams such as Aquaphor, baby oil, and aloe lotion. If pruritus or irritation is present, do not use these things 4 hours prior to treatment, as they may amplify the effects. Additionally, often baby products such as baby oil and baby lotions do still have alcohol in them, so examine any type of moisturizing cream or lotion for the ingredients listed on the bottle. Avoid cornstarch if yeast infection is suspected, as it causes the infection to spread significantly. Keep draining areas clean and dry to prevent infections. Avoid tight-fitting clothes with belts, buckles, and straps over the treatment area. Avoid direct exposure to the sun. Do not swim in a saltwater or chlorinated pool during treatment, and avoid shaving hair. Avoid deodorants, perfumes, powders, or cosmetics on skin in the treated area. And again, do not remove any markings made by the radiologist, as often these are needed for the treatment. GI problems and anorexia. Anorexia peaks during the 4th week of treatment and tends to disappear when treatment is finished. The patient needs to be reminded to eat small, frequent, bland meals because they may have difficulty swallowing, and to increase their carbohydrates and proteins. Oftentimes, Megace will be prescribed, as this increases appetite in patients who've undergone radiation. Additionally, the mucosal epithelium is lost within 1 to 2 weeks after treatment is begun, which can cause dry mouth, xerostomia, from damage to the salivary glands. The patient may be encouraged to use artificial saliva, such as Salagon, and hypogeusia, such as taste loss or alteration, is often experienced by the patient too. Stomatitis, mucositis, esophagitis, and gastritis are treated with antacids such as Myelanta, Benadryl, viscous lidocaine, or a medication called Carafate, which is diluted in water and drank, which provides a coating used for gastritis. These patients also need to be reminded to avoid lemon and glycerin swabs, as these are irritating and drying, and diarrhea can be treated with Questron, which binds to the bile salts and increases the consistency of stool. They also need to be reminded to keep the rectal area clean and dry. Nursing administration is aimed at administering antiemetics 1 hour before treatment. So Zofran, Compazine, and Phenergan are often given prior to the treatment. This slide shows a patient with several different stages of oral mucositis. Other side effects that can occur with radiation are sperm cell production that returns within 2 to 5 years, or maybe not at all. Often young males who undergo radiation may be encouraged to freeze their sperm cells, later being able to use them for reproduction. 95% of females have permanent amenorrhea if radiated to the pelvis. And there's pulmonary effects on patients, such as possible alveolar collapse, pulmonary fibrosis, and cough and dyspnea can also develop that requires O2. Chemotherapy. Treating cancer with chemical agents that promote cell death by interfering with cellular function and reproduction is known as chemotherapy. Chemotherapy plays a major role in cancer therapy, and it's used to cure and increase survival time. Some chemotherapies have selectivity for killing cancer cells over normal cells due to their increased growth and division. Normal cells that divide rapidly are most affected by chemotherapy, those including the skin, the hair, the intestinal tissues, the spermatocytes, and the blood-forming cells. And sometimes in chemotherapy, more than one drug is given to enhance its effect, producing a synergistic effect. The following slide has a link to a chemotherapy video that I think we will find helpful. Chemotherapy drugs. There are numerous classes of chemotherapeutic drugs, and most of them are aimed at impairing cell reproduction, stopping the RA or DNA protein synthesis, stopping meiosis and cell division, and various other stages of the tumors. I will allow you to review these slides on your own and to look at the different types of drugs and their side effects. Chemotherapy technique for administration is required to have special precautions to prevent complications, as most body systems are affected. Nursing care of the patient that's undergone chemotherapy focuses on the safety of the patient and the identification and management of side effects. Common hypersensitivity reactions in these patients include flushing, rash, anxiety, bronchospasm, and hemodynamic collapse. If this happens, it's important to stop the infusion as soon as symptoms are observed in your patient. Side effects of chemotherapy, one of the main ones is extravasation, which is infiltration into the surrounding tissues by the chemotherapy agent. The reduction of the incidence for this has been changed drastically, since most surgeons now are either using a central line, a portacath, or a Hickman catheter for chemotherapy infusion. If a peripheral site is needed for chemotherapy administration, it's important to check the IV site frequently for pain, blood return, swelling, and coldness. If extravasation is suspected, stop the infusion, aspirate any remaining drug, and inject the prescribed antidote. It's important to elevate the site, apply cold and warm compresses, and observe the site for necrosis and ulceration, as these patients may need a skin graft. Incidentally also, if a central line, a portacath, or a Hickman is used, then aspiration of blood through the line prior to administration of the chemo is crucial, as you need to make sure that the line is still in the appropriate area. If the line doesn't flush appropriately, then the physician needs to be notified and an alternate route of chemotherapy administration needs to be utilized. Additionally, with a portacath or a central line, it's very important, again, to monitor the site for swelling or elevation or redness or anything like that to make sure that your chemotherapy is not extravasating centrally. Chemotherapy-induced nausea and vomiting. Chemotherapy-induced nausea and vomiting could be decreased by administering antiemetics 30 minutes to 1 hour before chemotherapy administration and on a schedule. Cisplatin is a drug that can induce delayed nausea and vomiting, often happened 5 to 7 days after its administration. There are several different types of chemotherapy antiemetics. First one including the serotonin antagonists. They block the serotonin receptors of the GI tract and chemoreceptor trigger zones. These drugs are Zofran and Kytril. Dopaminergic blockers block the dopamine receptors of the chemoreceptor trigger zones and include Reglan. The neurokinin-1 receptor antagonists are Amend, and the anticholinergic antiemetics include Dramamine. Also, additionally, antipsychotics are often used as they change actions of chemicals in the brain, reducing the effect of the perceived effect of the nausea and vomiting. The common antipsychotics that are used in chemotherapy administration are Compazine and Trilofan. And oftentimes, these drugs are used in combination with corticosteroids, phenothiazines, sedatives, and antihistamines such as Vistaril for a synergistic effect. Another side effect of chemotherapy is mucositis, where the entire G-act epithelium ulcerates from the mouth, stomatitis, to the anus. The patient develops sores in the mouth and throat, and diarrhea and skin breakdown that are extremely painful. It's important to remember in mucositis to feed the patient anything they want at any time they want. Keep their skin clean and dry. Remind them that good oral hygiene is important. Soft bristled toothbrushes should be used. They need to make sure they're buying non-abrasive and using non-abrasive toothpaste. They can gargle with normal saline every hour while awake. Dental floss should not be used if it causes bleeding. And provide antacid and analgesic mouth swishes and swallows that will help with pain and reduce inflammation and sores. Monitor their weight, their serum albumin and prealbumin, and remember these patients will have altered taste, hypogeusia, which may dictate the use of different flavorings in foods than the patient normally eats. The other side effects of chemotherapy include cardiopulmonary toxicity. Adriamycin can cause irreversible cardiac toxicity. It's important in a patient who's receiving adriamycin or any types of cancers to have a pretreatment EKG, and additionally, the nursing staff needs to monitor the patient for signs and symptoms of congestive heart failure. Also, it's important to check for adequacy of pulmonary function, and this is often done with pre-treatment pulmonary function tests. Alopecia, or hair loss, can be whole body or just thinning of the hair. Hair loss is sometimes temporary, but often the regrowth may not be the same as the original hair, as it may be thicker in texture and a different color. If the patient knows they're going to be losing their hair, it's often good to plan ahead for a wig or scarves to enhance their self-worth. And injury protection and prevention and coping is priority in these patients. Other side effects of chemotherapy include fatigue, which is a commonly reported side effect and often develops during the third week of treatment. White blood cells, platelets, and red blood cells are often decreased, which decreases the oxygen carrying capacity of the blood, resulting in fatigue. Interventions include alternating periods of activity with rest, and walking has been found to decrease fatigue. Sleep hygiene, relaxing routines prior to sleep, small frequent meals, the prevention of tooth decay, because radiation therapy often causes xerostomia, and physical therapy or assistive devices are often used. Other side effects of chemotherapy include myelosuppression. Chemo destroys circulating blood cells and reduces replacement of these cells by suppressing bone marrow function, resulting in decreased production of blood cells. Leukopenia, which is decreased white blood cells, aka neutropenia, increases the risk for patient infection, and so the nurse needs to institute neutropenic precautions. Anemia, or the decreased red blood cells, results in hypoxia, fatigue, dizziness, and hypotension because the hemoglobin is carried on the red blood cell. Thrombocytopenia, or low platelets, results in hypoxia, fatigue, and increase in bleeding incidences, so it's important to prevent injuries in these patients. Incidentally, too, these patients have decreased protective and immune responses, and so they're at extreme risk for sepsis leading to death, and they can also have overgrowth of normal flora in the body. You need to manage their infection risk with biological response modifiers, if at all possible. Biological response modifiers, or BRMs, modify the patient's biologic responses to tumor cells. They stimulate the immune system to recognize cancer cells and eliminate or destroy them. The body produces a small amount of cytokines, which are the small protein hormones made by the white blood cells, which make the immune system work better. Science can now synthetically manufacture these cytokines, and they are used to stimulate bone marrow production of the immune system cells to help reduce risk for infection during chemotherapy. There are several different types of biological response modifiers. They include the interleukins, which is a group of 37 substances the body makes to help regulate inflammation and immune protection. They help different immune cells to recognize and destroy abnormal cells. Interleukin 2 and interleukin 6 charge up the immune system and enhance attacks on cancer cells. Interferons are another type of biological response modifiers, and the cell produce proteins that can protect non-infected cells from viral infections and replication. They slow tumor cell division, stimulate growth of the natural killer cells, induce cancer cells to resume normal appearance and function, and they're effective in the treatment of melanoma, hairy cell leukemia, renal cell carcinoma, ovarian cancer, and T-cell lymphoma. Thirdly, the colony-stimulating factors, or the growth factors, induce more rapid recovery of the bone marrow after suppression by chemotherapy. Neupogen, which can be given IV or sub-Q, treats neutropenia. Epogen or Procrit can be given IV or sub-Q, treats anemia. Aranesp can be given sub-Q or IV, and it helps with fatigue and anemia. And Numega, which can be given sub-Q or IV, is interleukin-2, which stimulates the bone marrow to make platelets, thus treating thrombocytopenia. Oftentimes, these biological response modifiers may be given several different ways and several different types. Biological response modifiers are not without side effects, and they include fluid shifts that cause edema in the tissues and organs, orthostatic hypotension, so monitor the patient's blood pressure. They may produce fever and chills that can be managed with Tylenol. Rigors may often occur and are managed with Demerol. Flu-like malaise, peripheral neuropathy, skin rashes, and skin dryness are all side effects of the biological response modifiers. The following slide shows pain assessment in the chemotherapy patient and how to manage it. Pain management in cancer patients is crucial, and there is often flowcharts for management of pain in these patients as to provide a systemized way to evaluate and treat chronic pain in cancer patients. Step 1 often has a patient using a non-opioid plus or minus an adjuvant. If the pain persists or increases, then an opioid is added for mild to moderate pain, along with a non-opioid and possibly an adjuvant. If the pain continues to persist or increase, then the opioid for moderate to severe pain is increased, the non-opioid is definitely used, and the adjuvant is also used, hopefully resulting in freedom from cancer pain. The following questions will be covered in class. Oncologic emergencies. There are several oncologic emergencies. The most common one that develops is sepsis. Sepsis is an infection that occurs in the bloodstream and or the urine. Most commonly, sepsis is identified through blood cultures in the bloodstream. It comes from infections within the body where the overwhelming infection spills into the bloodstream and bacteremia develops in the bloodstream. It's due to low WBCs and impaired immune system function, and its signs and symptoms include hypotension or a drop in systolic blood pressure of 10 millimeters of mercury, tachycardia, increased respiratory rate, febrile or hypothermic, altered level of consciousness, and it can lead to septic shock or multisystem organ failure. Management is aimed at using the Surviving Sepsis campaign and includes IV antibiotics, fluid boluses, blood cultures, and vasopressors. The Sepsis Bundle Society of Critical Care has a Surviving Sepsis campaign bundle that outlines the important steps of caring for patients with sepsis. Patients who are thought to be septic have certain steps that need to be completed within 3 hours, and these include a measurement of lactate level to determine lactic acidosis, obtaining blood cultures prior to the administration of antibiotics, the administration of broad-spectrum antibiotics, and the administration of 30 milliliters per kilogram of crystalloid solution for hypotension or lactate greater than 40 millimeters per liter. It's important in these patients that the crystalloid fluid be often normal saline. If the lactate level is normal, then it's appropriate to use lactated ringers. However, if the lactate level is high, it's important to not. To be completed within 6 hours, you want to apply a vasopressor for hypertension that does not respond to initial fluid resuscitation, and to maintain a mean arterial pressure of greater than 65. The most common vasopressor that's used in these patients is Levophed. In the event of persistent arterial hypotension, despite volume resuscitation, septic shock, or initial lactate of greater than 4 millimoles per liter, 36 milligrams per deciliter, then it's important to measure central venous pressure and to measure the central venous oxygen saturation of these patients and remeasure the lactate if initial lactate was elevated. Targets for quantitative resuscitation of patients with sepsis included in the guidelines are a central venous pressure of greater than 8 millimeters of mercury, a central venous oxygen saturation of greater than 70%, and normalization of lactate levels in the patient. Superior vena cava syndrome. Superior vena cava syndrome is compressed or obstructed by tumor growth, leading to the lack of blood flow to the head, neck, and upper trunk. Its condition can lead to a painful, life-threatening emergency. Early signs and symptoms of superior vena cava syndrome include edema of the face and eyes, Stokes sign, which is the patient experiences a tightness around the neck like a shirt collar, engorged blood vessels, edema of arms and hands, dyspnea, erythema, and epistaxis or nosebleeds. Late signs and symptoms include cyanosis, mental status changes, decreased cardiac output, and hypotension. And this slide depicts a young lady with superior vena cava syndrome. And if you'll note that her neck looks like it has a shirt collar around it, and she has developed edema below this level. The superficial veins of the chest are engorged, and you can note that on this slide. Collaborative care for the patient with superior vena cava syndrome includes high-dose radiation therapy in the upper chest for temporary relief of pain, high-dose corticosteroids to reduce swelling, and surgery may be possible as a metal stent often has to be placed in the vena cava in an interventional radiation department with follow-up angioplasty to keep the vein open. Remembering that superior vena cava syndrome is a late-stage manifestation, and oftentimes the tumor of the patient is usually widespread by the time this is discovered. Spinal cord compression. Collaborative management of patients with spinal cord compression includes early recognition and treatment, as these patients will develop intense, localized, persistent back pain that is increased with Valsalva maneuvers such as having a bowel movement. Numbness and tingling, unsteady gait, motor weakness, sensory paresthesias, and loss of bowel and bladder function often ensue. Treatment is often palliative, and high-dose corticosteroids are used to reduce swelling. High-dose radiation is used to reduce size of the tumor and compression. Surgery can be indicated, and external back or neck braces are often used to reduce pressure in the spinal column. Hypercalcemia occurs most often in patients with bone metastasis. Other tumors also release parathyroid hormone, resulting in hypercalcemia. Hypercalcemia results in decreased mobility and increase in hydration. Early signs and symptoms include fatigue, loss of appetite, nausea and vomiting, constipation, and polyuria. Late signs and symptoms include severe muscle weakness, loss of deep tendon reflexes, paralytic ileus, dehydration, EKG changes. And collaborative management of these patients includes oral hydration and normal saline IV for hydration, and drug therapy, such as calcitonin or mithromycin to regulate the calcium levels, or the biphosphonates, such as Fosamax, to inhibit calcium release from the bone. Pericardial effusion and cardiac tamponade. Pericardial effusion is an accumulation of fluid in the pericardial space, and it can lead to cardiac tamponade as the fluid compresses the heart and interferes with cardiac filling time and expansion. Diagnosis is done through an EKG, a chest X-ray, or a CT. And signs and symptoms include shortness of breath, orthopnea, fatigue, chest pain, increased jugular venous distension, compensatory tachycardia, and distant or muffled heart sounds with a rub or a gallop. Treatment for pericardiocentesis includes aspiration of the pericardial fluid, a pericardial window to drain the fluid out of the pericardial sac, or radiation. DIC, or intravascular disseminated coagulation. DIC is a condition in which normal clotting processes are activated systematically and uncontrollably. Platelets are blood cell fragments that stick together to seal small cuts and breaks in the blood vessel walls and stop bleeding. In DIC, blood clots form throughout the body's small blood vessels and in the major organs. The increased clotting uses up all the platelets and all the clotting factors in the blood, upsetting the balance between coagulation of circulating blood and the prevention of hemorrhage. Without platelets and clotting factors, extensive bleeding and fatal hemorrhage can occur. And DIC is caused by sepsis in cancer patients from the release of thrombin and thromboplastin from cancer cells or blood transfusions. If it's not corrected, infarction and organ failure can occur because the clots are now blocking vital blood flow to organs and the peripheral tissues. DIC management is aimed at early identification, and a DIC screen for the lab is often indicated. A DIC screen will have a PT, PTT, INR, platelets, fibrinogen, and another value called FDP, or fibrinogen degradation products. The fibrinogen degradation products and the fibrinogen are the hallmark of DIC identification. The normal values for fibrinogen are 2 to 400, and if a patient has a low or high fibrinogen, it means that they're either utilizing the clotting factors or have used them all up. Additionally, also, fibrinogen degradation products are the breakdown of fibrinogen and their ability to be measured. If fibrinogen degradation products are less than 10 or greater than 40, then it indicates a process of DIC. DIC management is aimed at treating the underlying cause aggressively and providing management of complications. In these patients, it's important to stop abnormal coagulation and control bleeding. Prevention is the best measure for these patients, as aseptic technique and management of signs and symptoms of infection help prevent the infection that triggers the sepsis that triggers the DIC. Collaborative management of these patients focuses on reducing infection and halting the process. Early in the stage of DIC, anticoagulation is often implemented by a heparin drip. Heparin slows the cascade of clotting events that makes the body overuse the clotting factors present. It does not get rid of the clotting that is there, but it stops the clotting process. Additionally, IV antibiotic therapy to treat the underlying sepsis or infection is definitely implemented. And then, replacing blood products that are abnormal is the hallmark of therapy. If the platelets are low, you infuse platelets. If red blood cells are low, you replace with red blood cells. Additionally, platelet or FFP provides clotting factors that are specific to the patient. So FFP can also be a hallmark of infusing for patients when DIC has progressed and hemorrhage is a primary problem. Additionally, specific factors of clotting can be infused, such as factor 7 and factor 10, and they are often used in late management of DIC patients. SIADH, or syndrome of inappropriate antidiuretic hormone. SIADH is most commonly found in carcinoma of the lung. Some brain tumors may cause secretion of ADH, and others stimulate the brain to make ADH. Usually, ADH is secreted only when more fluid is needed in the body. Increased ADH levels in SIADH lead to insufficient elimination of water from the kidneys and retained water in the serum. This leads to a dilution of serum sodium levels to a level of almost 115 to 120, where the patient experiences early signs of muscle cramps, loss of appetite, and fatigue. As the sodium falls below 110, these patients exhibit weight gain, nervous system changes, personality changes, confusion, extreme muscle weakness, seizures, coma, and death. Management is aimed at fluid restriction to prevent fluid overload, increasing the sodium intake by administering hypertonic 3% saline, and drug therapy such as declomycin, which inhibits ADH secretion and promotes water excretion. Tumor lysis syndrome. Tumor lysis syndrome is the rapid release of intracellular content from radiation or chemo-induced cell destruction. Cancer cells have abnormally high levels of potassium, phosphorus, and nucleic acids due to their enlarged nucleus. The release of these chemicals leads to electrolyte imbalances when kidneys can no longer excrete large volumes of these metabolites. Diagnostics for tumor lysis syndrome include a uric acid greater than 6, a phosphorus greater than 4.5, potassium greater than 5.5, or calcium of less than 8.5. Signs and symptoms of the patient are based on the electrolyte abnormalities, and treatment is aimed at managing specific electrolyte abnormalities.